เนื่องจากเมื่อสักครู่อาจารย์สวิทย์ได้แนะนำวิทยากรท่านถัดไปอย่างละเอียดแล้วนะครับก็ต่อไปก็ขอเรียนเชิญวิทยากรเลยนะครับ
ค่ะสำหรับเซสชันต่อไปนะคะเป็น keynote speaker เป็น Professor Sukika Butta นะคะในหัวข้อ How to implement instructional reform from informative to transformative เรียนเชิญค่ะ
So thank you very much, Swet, for those kind words, and thank you once again for the opportunity to speak to you. I realize this is the end of the conference, and you've already been busy the last 2 days in discussing various aspects of the Lancet Commission's report. What I was charged to do was to principally try and summarize the genesis of why this report was generated. What are its salient recommendations? Many of those have been highlighted by the rapporteur in his last presentation. And very quickly talk about where are we going, where has the world moved on since the release of this report some 5 years ago. So ladies and gentlemen, the first question that arises is why was this necessary, and why the question of a review of particularly health professional education at this point in time. This stemmed from a recognition amongst many of us working in health systems, health education, and the interface of the health education and health system, in that the world had changed dramatically over the period of time. And as we got into the 21st century, there were several issues that confronted all of us in public practice. One was the clear recognition that there was massive global epidemiological and demographic change. Second, that there was also now much greater professional differentiation than there was in the last century. Much greater classifications of health professionals, many cadres working together, disparate in different points in time. And as I mentioned yesterday, emergence of new systems and ways of task shifting as well as task sharing. It was also very clear that global population demands for both health and addressing social determinants of health had changed remarkably over the last century. And then, as has been mentioned again in the plenary presentation this morning, technology is not something that has become a novelty. Technology is with us. And we were very cognizant 5 years ago as we worked on this report that technology was an essential attribute of the new way of learning of the new generation. And medical education in particular had to embrace technology and find new ways of using it for betterment of mankind. This is also reflected in the range of things that have happened over the last 2 decades or so in relation to global health, starting with the signatories around the world who signed up to the Millennium Development Goals, the development very soon thereafter of this massive movement to rid the world of HIV and AIDS-associated premature mortality, the 3x5 initiative that people thought was virtually impossible, the studies and assessment of human resource distribution across the world, which was a very essential part of the Joint Learning Initiative, and then several declarations and World Health reports that I will allude to. Today, as I stand in front of you, within the next 1 month or so, the world will assemble again in New York to sign up to the Sustainable Development Goals, which are replacing the Millennium Development Goals in relation to the aspirations that the world will set itself for the next 20, 25 years. So this has been a very dynamic process, and in this process, at the time when we assembled, it was very clear that we were looking at shifting sands and were very cognizant of what change would bring us together. The World Health Organization had put out 2 landmark reports related to human resources for health, and I would urge all of you, if you have time, these are freely available on the web, to read these reports because they talked about both the differentiation and the challenges around distribution of human resources of health. They also talked about the relationship between health outcomes and health worker concentrations. This graphic that I show you here relates very clearly the maternal, newborn, child mortality to the relative density of health workers in various populations. And this density here is provided in a summary form, but can also be seen, as I showed yesterday, in relation to specializations and various cadres of health workers. In this differentiation and in these multidisciplinary, multi-categories of health workers, you have frontline health workers, the community health workers that we talk about working with people in the community, those that are much more in the so-called ancillary health worker grades, and professionals that are generally the apex of health professionals. Our report was principally to focus on the leadership level of health workforce, and therefore, quite rightly, we focused ourselves on health professional education related to leadership, its distribution within the health system, and the teamwork that relates to health professionals working together. The timing of the Commission's report was important. At the time when we got together, this was almost 100 years since the first landmark report, largely focused on North America, United States at that time, by Flexner, had looked at principally the medical education scenario in the United States. But Flexner was not alone in looking at education. There are two other landmark reports around that time that I have to point out. One was the equivalent of Flexner for nursing education, and the other was the report that related to the schools of public health and public health education in the United States. So our report in the year 2010 by the Commission was very timely in revisiting this issue after a century. As I said yesterday, there had been many efforts in the United States on looking at health education over the intermediate period, but this was perhaps the most systematic effort in terms of looking at its sense. The Flexner report was extremely important because at that time, when this was produced after a labor of love and effort, it looked at medical schools within the academic frames of the university. It made a number of recommendations, but it largely pointed out to the importance in medical education of faculties working in university platforms in very close proximity to laboratories and academic training facilities. It underscored the importance of faculty working with students who had had a thorough grounding in science. Just imagine yourself at the time when Flexner was generating this report over 100 years ago, that practice of medicine was moving from faith-based medicine to science-based medicine. This is around the time when the germ theory was setting in, and hence Flexner very rightly went around the United States garnering enough support for strengthening the scientific basis of medical education. And he was supported in his endeavors by the giants of his time, the Ostlers and others, who were principally underscoring the beginnings, the roots of evidence-based medicine and practice. There were two important recommendations that the Flexner report made. One was in the new vision for medical education, it talked about competence. It put forward for the first time the importance of competency in medical graduates and talked about the importance of practice, of learning by doing, of scientific thinking, of critical evaluation, critical inquiry, and the importance of applying this to clinical practice. Competence, clinical competence that we all talk about today. But the other important thing that the Flexner report put on the table, which was to determine the direction of medical education for virtually the entire last century, was the importance of the intellectual foundations of medicine. And this was the time when it became important for science foundations before you entered medicine. There is a reason why we now, almost across the world, have grounding of pre-medical education in physics, chemistry, biology. Prior to that, historically, even in the United Kingdom, you could actually move into scientific medical education from even a humanities and an arts background. We are now turning around to a large extent by not reducing the emphasis on science education, but the importance of bringing in additional discipline. But Flexner was the first in his report to underscore the importance of setting up the intellectual foundations of medicine. Our commission was led by, again, two giants of contemporary health sciences, Julio Frank, till recently the dean of the Harvard School of Medicine, and now the president of University of Miami, and Lincoln Chen, an established academic of global stature who was the head of the China Medical Board, secured support for this exercise and engaged an additional number of people from across the world. They've been very generous in calling the entire commission as leaders from diverse countries. We regarded more or less ourselves as also students working together to generate a lot of what you find within the report itself. So it was reasonably representative of a range of disciplines and people from various parts of the world. I happen to be the one member of the commission who represented the child health scenario, but there were many others who were leaders from the maternal health, midwifery, also from public health. The important thing about the commission was that irrespective of funding and support and our various origins, it was a completely independent exercise. And we worked as much as possible to garner the best evidence that was possible to underpin our mission. We deliberately included not only medicine, but also nursing and public health within our disciplines. So the three main apex professionals that were reflective of the Flexner report, the Welsh report, and the nursing report. Our product was a single report and subsequent modifications or products thereof, which was published in the Lancet as a Lancet Commission report in November 2010. In our work, we received inputs from a range of platforms, from particularly young trainees. So we were very pleased that we were able to get a lot of input from not only young trainees, but also medical students. There were regional consultations, and there was a fair amount of empiric research which went into the work of the commission to determine exactly what product it put out. And the commission put out a product which was, by design, global, multi-professional, looked at evidence and systems, and put forward recommendations that would guide, hopefully, education in the 21st century. The report was launched, and many of you, I hope, have received and read the report. It is a relatively short document despite its volume. It's actually much shorter than the Flexner report, and it focuses on a range of issues that I will try and summarize in the next 15 minutes or so. The three main areas that the report focused on was: what was the nature of the transformation that we were aiming for? What was the education system and the interface with the health system that we were aiming for? And what did we mean by interdependency in terms of our recommendations? The report is divided into 4 parts that you could readily go through: the background, a conceptual framework, our key findings from the empiric work that was done by the Commission, and then our recommendations for reforms for the 21st century. In terms of looking back and looking at how the world had changed and what was the demographic transition that we were all looking at, there isn't time to go into everything, but one of the most remarkable things to recognize over the last century, the 20th century, is how far we have come in terms of improved global health. One marker of that is life expectancy. So if you look at life expectancy, this is a Preston curve. And if you look at life expectancy in relation to GDP, income per capita, you find that over the last 100 years, life expectancy has gone up from about an average of 50 years to current 70 to 80 years. We've added 30 years within a century to global life expectancy for the human race. This has not happened in the entire history of mankind. And this is not something which is cast in stone. It is happening as we speak. Let me give you an example from some of my group's recent work where we have looked at Middle East and North Africa, not necessarily high-income countries, but a very tumultuous part of the world. If you look at the Preston curve for Middle East and North Africa, for countries which do not include the high-income countries of that region, look at the tremendous transformation and transition even within a period of 25 years. Remarkable change that we are seeing across geographies as people have access to better health, better education, and better practices at local levels. So the globe has changed in a remarkable way in terms of the health transition. It has also brought on top of that disorders, particularly non-communicable diseases, that were not necessarily the case 100 years ago, even 50 years ago. With increasing life expectancy, you're beginning to see an entire demographic and health transition that was, particularly for this region, never the norm. Today, in every country of Asia, Alzheimer's disease, dementia, care of the elderly is becoming a reality. Why? Because life expectancy has gone up. We are moving from a largely infectious disease burden to a burden that's a mixture of other disorders with relative contributions. As practicing pediatricians, we no longer deal with outbreaks of infectious diseases, but we deal with things that relate to a lot of other issues that we typically see in high-income countries. So there is this process of transition that the world has had. Within this is the contribution of increased global pool of knowledge, not just in knowledge in terms of net information, but also synthesized information, information that allows us to sift through this mass of information into useful practices. Some of this is related to technology, and you saw a wonderful demonstration this morning of how all of us in our own lives are now accessing and using technology to have access to the best information. And it's not just in health. It is in rural populations. I go to rural parts of South Asia, where I find that increasingly farmers have access to information using mobile technology that they could not even dream of 20, 30 years ago. So lives are changing. Our children are changing. Our children have information that you and I would need to go to a library to get. They have that at their fingertips. How many of you have recently ever read a paper encyclopedia? In my own lifetime, encyclopedias have disappeared. Everybody that I know now looks at the internet for their information. Wikipedia has decimated the traditional. All of this has happened within the last few decades. So the world is changing rapidly, and technology has had a big role to play in this. But more than just pure technology is the way synthesized evidence has affected policies and practices, but also affected household behaviors. Do not underestimate what role information has had in changing behaviors at household, not only amongst the educated elite, but also amongst lay people, people who have relatively lower level of education, even in the most remote rural populations. I work in Afghanistan. I go to the most rural parts of Afghanistan, and I find that people have access to information. They know about things that they could not even dream of knowing about 40, 50 years ago. So the world and its information, knowledge translation, particularly in relation to health, has changed rapidly. Within all of this epidemiological demographic transitions and the role of technological innovation is the impact that all of this has had on health systems, both in terms of population demands and expectation, but also the way professionals have interacted with the health system per se. Let me explain that in a minute. So I will explain that through a conceptual framework that the Commission set for itself to better understand the various elements of the health education system. So if you look at the two parallel worlds that interface in developing a health education system, you have first the education system, and you have the health system per se. And they both overlap to a certain extent, but they're not synonymous. The education system, and if you just think about it for a minute, you will understand. Those of you who are parents and have children you will understand that the education system has its own dynamics, which are related to many things that are aspirational on the parts of populations and nations. Also, the gearing of the education system to supply, according to market forces, products of the educational system. In Asia in particular, we as parents are very focused on getting the best education for our children, not necessarily only that they are well informed, but also that they should have careers, that they should have careers and be able to join a workforce and live a better life than us. In other parts of the world, education is an end in itself. You want people to have access to information because they should become better individuals, more informed individuals. So education system has its own dynamics, and the health system has its own dynamics because the health system has its own demands which relate to population needs, and to provide for those demands, it requires a certain amount of labor and health professional workforce, which is also dependent upon what your educational system can produce. So the important thing for us to recognize was how these two systems interface and how in a given country these two systems have to work in tandem. I've had the good fortune of listening to many of you in your wonderful country over the last day and a half as to how your innovations of producing doctors for every district, your innovations of balancing your workforce across the needs of your country have led to the structuring of the education system, the health education system, in that direction. In other places, this is not necessarily the case. Thailand is very focused on producing health workers for Thailand's needs. In many countries, health workers are being produced for export because it has been worked out. It has been worked out by many people and economists that their net contribution to their economy is probably better as expatriate workers rather than workers working within their own geographies. This is the sad but real economic reality of how the market forces of the education system and the health system interface. The key components of the educational system, particularly the health educational system, are the institutional designs and instructional designs. And I will not go through that in any detail right now, but I'll come back to it in a minute. And there are some issues here which are systemic, which relate to governance and stewardship. How is this financed? And how is this organized at the level of both the public and the private sector? Regrettably, at the global level, until very recently, and even now it is a bit haphazard, the whole system of health professional education and medical education has had no governance structure. The reports that I've talked to you about, Flexner, Welsh, are all reports that were North American based. They were not tailor-made for the globe. So governance of health professional education and medical education has sadly been left entirely to market devices. So United Kingdom has its own governance system, but recognizes that the Royal Colleges are a big attractant that will bring people from all over the world, and same is true for many other geographies. So this aspect of global stewardship and oversight of medical education has been sadly lacking and has only really functioned in some ways around regulation and certification. In terms of instructional design, we are still living in the Flexnerian era, where a lot of emphasis is on criteria for admission. What competencies are we going to provide to graduates, channels, and career pathways? That is still the traditional way, even today, of how medical colleges, schools coordinate their admission, training, and certification processes. And why is this important to know? I'll come back to this towards the end because it is archaic in the way how we do this. The outcomes of both of these educational system processes, which have not necessarily happened, is that instead of interdependence, this structure traditionally has led to a lot of independence. So even within the health professions, the segregation of doctors from nurses, from midwives, from public health professionals has been largely determined by the way we have structured our medical education system. And we have created, to a certain extent, these hierarchies of practice. I don't know about Thailand, Professor Suit is here, but I can tell you that in my part of the world, in India, in Pakistan, in Bangladesh, the people who go into public health for formal education represent the bottom 10% of classes. They represent those who cannot go into specialization, cannot find another job, and move towards community health or public health. Those segregations of hierarchies of training we have set ourselves and was very evidenced in the independence of various educational streams. And to this, we added the element that if we wanted to transform this, what would we need to do? So let me turn to the major findings of our report, and I will do this in a sequence before I come to the recommendations. The first one was that the world was created completely unequal in relation to medical education. So if you look at the density of medical schools by various regions of the world, you will find that in the part of the world where you have maximum morbidity and pathology, you have the lowest density of medical schools. And in numeric terms, you are looking at many countries with less than 2 medical schools per 10 million population. Unbelievable, but that is what it is. You also found virtually the same, and if anything worse, indicator in relation to the density of public health education. So if you were to look at what is the distribution of public health schools, you'll find that even in many middle-income countries, there are hardly any public health schools. In India, with 1.25 billion people living in this geography, look at the density of public health schools is less than 3 to 5 for the entire country. And that is clearly a reflection of what I've just told you in terms of the demand creation from the health sector itself for better drivers of where people go for specialization. Clearly, as I showed you this slide yesterday, this is a complete mismatch, not just with population, but also with burden of disease. That the countries, the regions, Asia, South Asia, Africa, where we have much greater need, we have very little production of health workforce, particularly health professionals. If you look at the distribution of countries by medical schools, the point that I want to highlight here is that there are a large number of countries with no medical school in the entire country. They include 27 countries in Africa. 27 countries in Africa with reasonable populations do not have a single medical school for their entire population. They would have to depend upon either importing physicians or some ancillary processes for meeting their population health. So as we move towards universal health care, this maldistribution of the production of health workforce will have to be taken care of. Yet, there is growth of medical schools, exponential growth in many places. We'll give you 2 examples, India and Brazil. Just look at what has happened in the last 2 decades on the growth of medical schools in Brazil and India. But it doesn't take a rocket scientist to see where is this growth. It's largely in the private sector. And some of these schools in the private sector are what I mentioned, are for export. Did you know that in India and in Nepal, there are medical schools there, private medical schools, where the fee structure is as high as medical schools in North America, where people have a waiting list that goes for years and years. I happen to come from a private sector medical school where at the very institution of the medical school in 1983, we put down that nobody would be refused admission on the basis of needs. But many medical schools are not like that. So the growth is lopsided. And you can well imagine if somebody pays $50,000, $60,000 for medical education, they're not going to come out at the end of that medical school and go and work in a rural population for free. So it is driving also the direction that many of these students and families are going. Now, don't be under an illusion that the investment in medical education is adequate. What our commission found was that if the global expenditure on health care was around $6 trillion, $6 trillion, what we are spending on medical education is less than 2% of that. That's the global number. It is actually much worse in the United States. If you look at the United States, half of the global expenditure for health, when we estimated, was in the US. Thankfully, it's going to come down now with affordable health care. But if you look at the United States, of the $2.5 trillion spent on health, less than 1% were being spent on medical education, on health education. So this is completely different from what we have in other disciplines: engineering, economics, law. I mean, the proportion that is spent on producing adequate health professionals or professionals for the kind of global needs that we have is completely lopsided. So our assessment was that over the last century, there had been tremendous progress. And I mentioned this yesterday, that the bright side of the moon is that we have highly skilled professionals who are knowledge brokers, who are management leaders. They are value-based social agents, and these health professionals have multiple roles in the health system. But our system has also produced a dark side of the health profession, particularly of apex health professionals. And one is that there is a monopoly of knowledge and not a lot of interdependency. It has distorted labor markets, as I've just told you. There are financial self-interests within physicians, particularly in the super specialists, who earn about 10 times more than what you primary care physicians earn. There is a credential creep that has come into our discipline. And by and large, most people would agree that there is also, by virtue of these market forces, an over-specialization. And this is a significant contributor to the whole issue of inequities in health that we talk about. These systemic failures, ladies and gentlemen, of the mismatch of competencies to health, of weak teamwork, of even gender stratification. So I haven't spoken about the gender mismatch in health professionals. There was an assessment not that long ago in North America of academic medicine in which it was very clear that there was a glass ceiling everywhere for females in academic medicine. It's being removed, but in middle income settings, gender stratification exists. There is a dominance of hospital practice over primary care, and who knows it better than those who live and work in the United States, and labor market imbalances. So what were the recommendations that our commission made? So all of this sob story and this dark doom and gloom was not unexpected. We expected this. The recommendations that we made were, in my opinion, quite revolutionary in terms of thinking what this century would look like if we only had countries, professionals, and people willing to accept it. We made one clear recommendation of reform. We said that if at the beginning of the last century there was a science-based movement, what I mentioned under Flexner, of developing a scientific curriculum and university-based education, the movement towards the middle of the last century, if not the middle, a little later, of problem-based learning was a very welcome move because it took away from the direction of a pure science-based to a problem-solving mechanism of education. Sadly, it wasn't picked up by everybody. It was only the McMasters and others of this world who took that on as a means of medical education. We felt that it was now time in the new century, in the 21st century, for us to move to a competency-based education model, which, although focused on solving problems locally, was based on best global evidence and connectivity. And we said that it required a reform in both your health and education system. It could not be done by the education system alone, nor could it be done by attracting people through reforms within the health system only. It required an interface between the health and education system. How? We believed that the transformative learning that we were aiming for required a change in our concept of integrated learning or interdependence in learning. The idea being that you move from individual patient-centered care, which still needs to exist, to a lot more emphasis on population-based care. A lot more emphasis on educational and health systems being aware of population needs at scale. What used to be called public health needs. We want to call that population-based needs. And this would be the one reason why we will achieve equity in health. Why? Because this would look at not only needs of the haves who have access to specialized care and specialists in hospitals, but this would also look at preventive and promotive care for those who live in marginalized, poor populations. We made several instructional recommendations and institutional recommendations. The instructional recommendations are detailed in the report, you should see them, but very briefly. The instructional recommendations were to move to a competency-driven curriculum, largely responsive to local needs, but completely dependent on inter- and transprofessional education. We made a clear recommendation that you would use technology that is available to us today, and emerging technology, for using its power to enhance education opportunities. And although this is 5 years ago, our vision that this would also be a great leveler, it would reduce the gap between the haves and have-nots, even in the medical education system. When I was in medical school, if you were rich, you went and bought a textbook. If you were a poor medical student, you signed your name in a library and had that book lent to you in turn when it became available for 10 days. And in those 10 days, you spent time writing notes because you could not afford to photocopy it. That has changed dramatically. Today, whether you are rich or poor, you have access to information if you have that kind of access to technology. So educational resources powered by new information allow us to bridge the gap in medical education between well-endowed and less well-endowed institutions. And the growth of multiple open access courses. Today, a medical student in Bangkok, a medical student in your provinces, in Chiang Mai, would have access to learning materials that students use at Harvard. My institution, Sick Kids, is just about to put out the first public health nutrition course, completely free to anybody, anywhere in the world who wants to have access to it. This was unbelievable just 20 years ago. So this reform, instructional reform, the way we teach, the way we make access to information is critical to learning, but it requires that we move from a very siloed, credentialing-focused, elite education approach to a much more interdependent and egalitarian approach to medical education. This also means that institutions should not work in their centers of excellence anymore, that there should be no gradient of this is Harvard, and this is BU, and this is Tufts, and this is everybody else. That within the same educational system, in a given country, that institutions have to work together to set standards and norms, which also means that you move from academic departments to academic systems. Now, I can challenge you that even today in Thailand, which is a much, much, much better system than many other countries, that you have residencies and training programs which are centered around institutions and hospitals. Now, can you imagine for a moment that if we were training and educational programs that were not centered around institutions, but centered around geographies, that related to the needs of a province or a district, whereby institutions would collaborate with each other, because students have the opportunity of moving and training in various institutions. This is happening as we speak between various institutions that are partnering in terms of this new approach to interdependent training. Increasingly, we have stated that we needed to move towards global networks and coalitions of groups working together to achieve a certain sense of common mission and vision. The enabling actions needed for this need to start at the top, that we needed to mobilize leadership in medical education within countries and within regions, and we needed more money put in health. You cannot do this for just a 1.5% investment in health education for trillions of dollars, $6 trillion being spent on health. And we need to make sure that there is some accreditation alignment between countries and within countries. So the hierarchies of power that come from one degree being valued more than others has to diminish and disappear over time. And this would in turn lead to strengthened global learning. Now I'm running out of time, so I will very quickly go through a few graphics. So the traditional model of a curriculum leading to educational objectives and assessment, we believed needs to move to a competency-based educational model where the competencies in relation to the health system needs determine the curriculum, but the curriculum does not determine the assessment. It is the competencies that determine the assessment that you have within the system. Also, I want to very quickly underscore that we are not just talking about interprofessional education. So currently, the models of medical education is nursing separate, medicine separate, public health separate, and others. And then we expect that after they graduate, there will be teamwork. This can never happen because you're creating a hierarchy of people who are unequal in terms of their background, training, and experience. We want that to change. And one way to change that is to move from this hierarchical system to an interprofessional educational system where these groups of people work together in systematic teamwork, not only when they graduate, but during the process of their education. Now, many people don't understand it. When I went back to Pakistan 30 years ago at the Aga Khan University, the first laboratory I came across was a multidisciplinary laboratory. After a few weeks of my joining, I went to the laboratory and saw that there were doctors supervising medical students and nursing students. Same lab, same experiments. It was a multidisciplinary lab. And for many people, that was a bit of a shock because we had never seen that level of integration. Now, it only existed for the first 2 years of the curriculum, but that integration was a reflection of the kind of integrated learning that we want to see as we develop these models of care. And what we are now looking at is not just this interprofessional, traditional way of education, but what we call trans-professional education, which not only brings in these disciplines, but also increasingly interfaces with the community and primary care workforce, which I believe are critically important to building teamwork and models of care. So trans-professional or trans-professional models of care need to bridge the traditional systems of health professional gradients that we see. The three main recommendations that we have made in terms of movement in the 21st century for learning is to move from informative learning, which typically tends to produce experts because it's based on a combination of information and skills, to formative learning, which increases the social contract, social values and socialization of your trainees, to producing professionals, to what we are truly calling transformative education. And transformative education, as opposed to these two forms of education, will produce leaders or change agents. And that's the objective, that if you aspire to produce leaders in your health professionals as you develop them, even if not all, but even if 15 to 20% of them assume that role, you would have succeeded in your task of transforming health systems and producing equity and universal health care. Is this a pie in the sky? Is this a dream? Was this just 20 people who got together and dreamt of something which was utopian? The answer is no. We were supported in our concepts and thoughts by the knowledge that across the world, already institutions had developed models of innovation. And that most of what I've told you just now was already happening, although at small scale, and although at limited institutional level. And these are just some of the examples of institutions. They include your own country and institutions therein, countries within Asia, where models of this kind of transformative education were already being placed and scaled up. So what's new in the report? The report emphasized that the future will be different from our past, and that it will relate to rapidly changing global epidemiology and the mismatch, addressing the mismatch of the competencies to the needs of population health. The reality of globalization of health education is amongst us, so it will create opportunities for innovation to level the playing field, to ensure that we use some of these opportunities of globalization and technology to principally look at how the students of tomorrow can benefit. And this was, our report was the first recent study of global professional education. We presented a new integrative framework, which makes sense to many people, is considered kind of ideal by others, but it is an integrative framework, and it encourages the three professions to go beyond their silos to a much more systems approach in the new century. There are many challenges. As I mentioned yesterday, the one big challenge is that this is not inexpensive. It will require greater investment. Don't be under the illusion that community-oriented or public health-oriented, population health-oriented medical education is inexpensive because it is somehow or the other a lesser form of education. It generally requires resources, particularly around the implementation and linkage of institutions to population health in districts. It will require efforts to increase faculty time allocation and compensation and accreditation to support compensating people for education at par, if not more than research. At the moment, as I mentioned yesterday, education is the poor cousin. In promotions, if you put forward, I have developed these 3 courses and here is my evaluation of course competence, it is not valued as much as a paper in the Lancet. This has to change. We have to accredit education with the same academic achievement gradient as we have for research. Education institutions, which many institutions are neither capable of nor resourced. So this requires a discussion within the health system and governments as to how does the education system interface with the responsibilities of the health system. There are competency and certification requirements that will have to be worked out. As I said yesterday, we have to balance local and global. You don't want to produce medical graduates that are good for Thailand, but really not good for the region. That the moment they step out of your geographies, they are incapable of working in other places because they have neither the knowledge nor the competence. That should not happen. So we have to find a balance in terms of how we do this. And we do not create hierarchies of professions. So very important for me, and this is a personal crusade for me since I'm a pediatrician myself and I happen to be a specialist pediatrician, I'm a neonatal pediatrician, it's very important that my trainees who are doing public health and primary care do not feel that they are any lesser qualified or any lesser remunerated than neonatologists in hospital. Lastly, what has happened in the last 5 years? You've had a good summary from your rapporteur. Firstly, this report was very well received. It was much better received than anything else that I've ever published in the Lancet. A lot of receptivity. There were sessions, seminars. There was also a rapid uptake in some regions. So this region, this country in itself was amongst the leaders. India's taken it. 2 countries in Latin America have taken it. East Africa, notably in Kenya and Tanzania, and some centers in the United States, and also one in Canada, have taken up this and are there preparing to walk the talk. There is this global health movement where this has become much more mainstream, less so within traditional medical systems. So I think it's early days, 5 years is not a long time, but there is a lot of discussion on how this can interface with global health and public health systems. So the Consortium for Universities in Global Health has adopted this as one of their mainstreams in terms of taking this forward as what they might recommend. Very recently, just a few months ago, a few individuals named here have gone ahead to even establish a new future medical school, international new school of medicine. This is very early days, but some of the principles that they outline in their concept of what an international new school of medicine would look like are very interesting because they are entirely based on our commission's report. Firstly, a Rollings admission program, which is based on an assessment of what these individuals would need to do, and a tailor-made educational assessment of the individuals coming from whichever disciplines they are coming for, leading to individualized learning. And a selection criteria, not on the basis of science competence, but on the basis of temperament and commitment of challenges to providing primary care for underserved populations. What Jason and Douglas also point out is that they would be dependent upon self-learning and small groups, as well as simulation, as a means of improving quality of education that they will impart. And they will base their clinical training much more on ambulatory and primary care settings, as opposed to hospitals or tertiary care facilities. They've also talked about the need for them to train their faculty and recruit them on this mission, and have them participate in educator development programs. And this adaptive learning and customization will also mean that some people will graduate within a minimum amount of time, and some will take their own time in terms of reaching a certain level. So there is no, therefore, fixed academic calendar or curricular needs. It's quite revolutionary, and it is fairly early, and there has been a lot of debate on the detail here. But this is not a pie in the sky. This school's been established, both in the United Kingdom and in Florida, with support from many leaders in global health education. So, ladies and gentlemen, as I finish, it is very clear that in the knowledge that we have to swim through in the 21st century, there has to be a link between the production, translation, implementation, and reproduction of knowledge. And I want to finish with this quotation from Louis Menand, who said very importantly that the ability to create knowledge and put it to use is an adaptive characteristic of humans. However, it is how we reproduce ourselves as social beings and how we change is how we get to keep our feet on the ground and our head in the clouds. So the Commission's report may be a little bit, in terms of our head in the clouds, aspirational, futuristic. But if we don't do it at the turn of the 21st century, as health professionals, as public health professionals and educators, I think we'll fail an entire set of generations to come. Thank you very much for your attention.
Thank you very much. Is there any questions or comments from the floor?
I have to catch a flight, but I'll be happy to take any questions. And let me take the opportunity to thank the organizers for the opportunity to be with you.
Sufi, thank you very much for a very comprehensive presentation. There are so many things that the Lancet paper recommend. If you can choose, what should be the 3 most important recommendations for us to move forward?
There are many dependent upon each other, so you probably cannot entirely cherry pick and take one without the other. But you have asked me a question, so I'll give you my own take on this. The first would be joint planning. So I don't think any institution, any organization, any government should rush into implementing this without a thorough discussion and preparatory process. That joint organization is a discussion between the education system and the health system in terms of how do you plan your health workforce for the next 20, 30 years. And the opportunity is now, Pisaki. Universal health care and the SDGs cannot be achieved without that level of health resource planning. SDGs cannot be achieved by just planning within health. They have to include your education system, they have to include environment and a whole lot of other things. The second thing that I would say, which would be transformative, is this trans-professional education. Practice with this. It is not something that can happen after people graduate. We need to move our, I shouldn't call them medical schools, We need to move our health education schools and systems to a model where people are working and learning together with a whole cadre and range of workers, nurses, midwives, ancillary health workers, and community health workers. I think there is great opportunity of learning from each other, and it will teach some of us physicians a little bit more humility in terms of how we develop hierarchies of power. The third and most important is a distributive system, whereby our education system becomes much more aligned to primary care and prevention, as opposed to the whole movement towards over-specialization and creation of apex professionals whose needs and requirements within a given health system are relatively less. The US is recognizing its mistake now. And in order to meet the requirements of the affordable health care, they will have to struggle very hard over the next 10 to 15 years to produce the primary care physicians who are attuned to that kind of public health need. Those three things I would highlight.
Thank you very much, Dr. Butta, and for your excellent and conclusive presentation, and I wish you have a good flight back home. Thank you. Please give him a big hand.ลำดับต่อไปนะคะ เราจะ
ก่อนที่เริ่มพิ
ก่อ
ธี
นจะ
ปิด
เริ่มพิ
นะค
ธี
รับ
ปิดนะคะ
เราก็จะมีการจับรางวัลตามที่เคยได้คุยเอาไว้นะครับโอเค
ค่ะท่านผู้มีเกียรติท่านใดที่ยังไม่ได้กรอกแบบสอบถามของเรานะคะแบบสอบถามทั้งสีฟ้าแล้วก็สีส้มนะคะก็ขอความกรุณาช่วยกรอกแบบสอบถามสำหรับการปรับปรุงนะคะหรือว่าการที่จะทำให้การประชุมของเราเนี่ยมีประสิทธิภาพเพิ่มมากขึ้นในลำดับต่อไปนะคะเราจับฉลากกันเลยต่อ
ไปเดี๋ยวเราจะเริ่มจับฉลากนะครับสำหรับท่านที่ได้ตอบแบบสอบถามนะครับแล้วก็มีฉลากอยู่ในกล่องเดี๋ยวอาจจะขอกราบเรียนเชิญท่านศาสตราจารย์นายแพทย์วิจันต์พาณิชย์นะครับกรุณาจับรางวัลนะครับอาจารย์ครับขอไว้สัก2 อันครับอาจารย์เผื่อครับโอเคนะครับเดี๋ยวขอเวลาจัดเตรียมสถานที่นะครับสำหรับพิธีปิดนะครับสำหรับผู้ได้รับรางวัลนะครับ
เดี๋ยวก่อนค่ะเรามีประชาสัมพันธ์เล็กน้อยก่อนนะคะนิดนึงนะคะนิดนึงเราต้องมีนะมีโมเมนต์แบบนี้บ้างอะไรบ้างนะคะมีประชาสัมพันธ์นิดหน่อยนะคะสำหรับข้างหน้าถ้าเกิดว่าท่านผู้มีเกียรติท่านใดอาจจะได้ผ่านแล้วก็เจอบ้างแล้วนะคะมีนวัตกรรมนะคะนวัตกรรมสอนคนไข้ให้เป็นหมอจากโรงพยาบาลราชบุรีนะคะซึ่งอาจารย์เขาเรียกว่าอาจารย์หมอตู้นะคะถ้าอาจารย์ท่านใดสนใจจะดูนวัตกรรมของโรงพยาบาลราชบุรีเชิญได้ด้านหน้านะคะจะมีอาจารย์หมอคอยแนะนำนะคะว่านวัตกรรมของท่านเป็นยังไงนะคะ
สำหรับเราพร้อมให้ประกาศเลยไหมครับ
ได้แล้วค่ะเชิญเลยค่ะได้แล้ว
สำหรับผู้โชคดีในวันนี้นะครับสำหรับผู้ที่ตอบแบบสอบถามนะครับหมายเลขที่ออกนะครับ350ครับ350ไม่ทราบมีท่านไหน
ท่านผู้มีเกียรติท่านใดถือหมายเลข350อยู่ในมือบ้างคะ
อยู่ในห้องนี้ไหมครับ
สีฟ้า350ค่ะ
350ครับ
เรามองไม่เห็นผู้ใดเลยนะคะตอนนี้
เพราะว่าแสง2 ตานะครับมองไม่เห็นครับแต่มีท่านไหนเบอร์350ไหมครับ
ส่งเสียงก็ได้ค่ะเรามองไม่เห็นมือเราขอเสียงก็ยังดีนะคะ
แต่มีค่านะครับกล้องวงจรปิด
เป็นกล้องวงจรปิดสำหรับให้ท่านติดไว้ที่บ้านนะคะแล้วก็สามารถที่จะส่งสัญญาณมาที่โทรศัพท์มือถือของท่านเพื่อที่ท่านจะได้ไว้สำหรับจับโจรหรือเปล่าเอ่ย ประมาณนั้นนะคะต่อไป
2
นับ1 ถึง 3
ครับไม่มีนะครับ
ไม่มีแล้วค่ะ
งั้นเบอร์ถัดไปเบอร์343มีไหมครับ
343ค่ะ343มีค่ะ
343นะครับ
ทางโน้นค่ะ
โอ้ครับเชิญเลยครับอาจารย์ครับครับเดี๋ยวกลับเรียนเชิญอาจารย์สุวิทย์นะครับมอบรางวัลชิ้นสำคัญครับอาจารย์ครับครับครับ
ขอบพระคุณอาจารย์สุวิทย์และผู้โชคดีเป็นอย่างสูงค่ะ
ครับ ขอแสดงความยินดีด้วยนะครับ
ค่ะขอประกาศอีกสัก
ประกาศอีกสักเรื่องนะครับเนื่องจากว่าการเตรียมพิธีปิดนี่ค่อนข้างซับซ้อนนิดนึงนะครับ
ค่ะสำหรับการประชุม Health Professional Education ในปีหน้านะคะจะจัดขึ้นในระหว่างวันที่ 21 และ 22 พฤศจิกายน 2559 นะคะซึ่งท่านผู้มีเกียรติท่านใดสนใจหรือว่าอยากจะติดตามความเคลื่อนไหวของมูลนิธิก็สามารถเข้าไปเช็คนะคะหรือว่าดูข้อมูลต่างๆเกี่ยวกับมูลนิธิและเรื่องการจัดการศึกษาสำหรับบุคลากรด้านสุขภาพนะคะได้ที่ www.healthprofessionals21thailand.org ค่ะ
ครับซึ่งก็จะมีรายละเอียดทั้งหมดรวมทั้งจะมี YouTube นะครับกิจกรรมทั้งหมดที่เราดำเนินงาน2 วันที่ผ่านมานะครับอยู่ในเว็บไซต์นั้นด้วยนะครับก็สามารถที่จะเลือกดูได้แล้วก็ศึกษาเรียนรู้ไปด้วยนะครับไม่ทราบทีมงานพร้อมหรือยังครับ
ทีมพิธีปิดของเราพร้อมหรือยังคะ
โอเคครับเขาก็โอมาแล้วนะครับ
ค่ะในลำดับต่อไปนี้นะคะจะเป็นการแสดงพิธีปิดงาน Second Annual National Health Professional Education Reform Forum นะคะ Instructional Reform for Competent and Humanized Health Professionals ปฏิรูปการเรียนรู้สู่สมรรถนะและหัวใจ
ครับซึ่งแนวคิดของการพิธีปิดในครั้งนี้นะครับก็จะมีเด็กมาเป็นตัวแทนของการเรียนรู้นะครับซึ่งเด็กก็เปรียบเสมือนเมล็ดพันธุ์ที่จะเจริญงอกงามได้ด้วยความดีแล้วก็ความรู้นะครับที่ต้องถูกถ่ายทอดจากพวกเราทุกคนนะครับเปรียบเสมือนเป็นผู้ใหญ่เนี่ยนะครับผู้เชี่ยวชาญของคือพวกเราทุกคนในที่นี้ก็ต้องใส่ใจดูแลนะครับแล้วก็มุ่งเน้นสมรรถนะของผู้เรียนอย่างเข้าใจรวมทั้งคำนึงถึงกระบวนการเรียนรู้สร้างสภาพแวดล้อมให้กับผู้เรียนนะครับจึงจะทำให้เมล็ดพันธุ์เหล่านี้เจริญงอกงามและเมื่อทุกท่านพร้อมแล้วนะครับเรียนเชิญพบกับพิธีปิดได้เลยนะครับเชิญเลยครับ
ของเราที่ซื่อตรงได้ทุ่มกายใจเนื่องแน่นับร้อยปีสู่ความเป็นจริงที่ยิ่งใหญ่ให้เราเท่านั้นเป็นผู้เดินนำบนหนทางสดใสพรุ่งนี้คือวันของคนรุ่นใหม่จับมือกันไปสู่ฝันจะเป็นใบไม้ใบหนึ่งที่แข็งแรงจะรวมกันเป็นพันเป็นหมื่นล้านใบจะรวมกันเป็นต้นโพต้นใหญ่กิ่งก้านนั้นกว้างไกลไปแสนนานพลังใบไม้รวมตัวด้วยหัวใจก็จะพาเราไปได้ดังต้องการเหน็ดเหนื่อยเพียงใดขอเพียงไม่หวั่นขอให้มีเราขอให้มีกันตลอดไปด้วยความฝันบวกกับหัวใจของเราที่ซื่อตรงได้ทุ่มกายใจเนื่องแน่นับร้อยปีสู่ความเป็นจริงที่ยิ่งใหญ่ให้เราเท่านั้นเป็นผู้เดินนำบนหนทางสดใสพรุ่งนี้คือวันของคนรุ่นใหม่จับมือกันไปสู่ฝันจะเป็นใบไม้ใบหนึ่งที่แข็งแรงจะรวมกันเป็นพันเป็นหมื่นล้านใบจะรวมกันเป็นต้นโพต้นใหญ่กิ่งก้านนั้นกว้างไกลไปแสนนานพลังใบไม้รวมตัวด้วยหัวใจก็จะพาเราไปได้ดังต้องการเหน็ดเหนื่อยเพียงใดขอเพียงไม่หวั่นขอให้มีเราขอให้มีกันตลอดไป
และน้องๆซึ่งเป็นเมล็ดพันธุ์ตัวน้อยของเรานะคะจะนำเมล็ดพันธุ์ให้กับผู้เข้าร่วมการประชุมนำมาปลูกไว้ที่กระถางหน้าเวทีนะคะซึ่งเปรียบเสมือนการปลูกเพาะเมล็ดพันธุ์แห่งการเรียนรู้ค่ะ
จะรวมกันเป็นต้นโพต้นใหญ่
เรียนเชิญท่านที่ได้รับเมล็ดพันธุ์นะครับมาวางเมล็ดพันธุ์ไว้ที่กระถางด้านหน้าเวทีเลยนะครับ
ค่ะท่านที่ได้เมล็ดพันธุ์นะคะ
เชิญเลยนะครับ
ช่วยร่วมเป็นเกียรติปลูกเมล็ดพันธุ์ที่กระถางของเราด้วยค่ะ
เหน็ดเหนื่อยเพียงใดขอเพียงไม่หวั่นขอให้มี
ด้านหน้าเลย
ด้านหน้าเลยค่ะบนเวทีเลยค่ะที่กระถางด้านหน้าเลยค่ะ
ท่านเชิญเลยครับสิ่งมหัศจรรย์อาจจะเกิดขึ้นนะครับ หลังจากเราได้ช่วยกันวางเมล็ดพันธุ์เหล่านั้นลงไปแล้วนะครับเมื่อเมล็ดพันธุ์แห่งการเรียนรู้งอกเงยนะครับก็จะกลายเป็นต้นไม้แห่งปัญญาที่จะเติบโตใหญ่ขึ้นนะครับแล้วก็จะต้องได้รับการดูแลด้วยความรักความเข้าใจจากพวกเราทุกคนในที่นี้นะครับ
ด้วยความฝันบวกกับหัวใจของเราที่ซื่อตรงได้ทุ่มกายใจเนื่องแน่นับร้อยปีสู่ความเป็นจริงที่ยิ่งใหญ่ให้เราเท่านั้นเป็นผู้เดินนำบนหนทางสดใส
ครับเดี๋ยวท่านอาจารย์สุวิทย์นะครับประธานจัดงานนะครับจะวางเมล็ดพันธุ์
จับมือกันไปสู่ฝัน
เมล็ดสุดท้ายนะครับ
จะเป็นใบไม้ใบหนึ่ง
ซึ่งจะเจริญเติบโตเป็นเมล็ดพันธุ์ในการจัดประชุมครั้งหน้าต่อไปนะครับครั้งหน้าก็จะเป็นเดือนพฤศจิกายนครับ
กิ่งก้านนั้นกว้างไกลไปแสนนานพลังใบไม้รวมตัว
ครับเมื่อเมล็ดพันธุ์แห่งการเรียนรู้งอกเงยนะครับก็จะกลายเป็นต้นไม้แห่งปัญญานะครับที่เติบโตได้แล้วก็ต้องได้รับการดูแลด้วยความรักความเข้าใจจากพวกเราทุกคนในที่นี้นะครับขอเสียงปรบมือให้กับทุกท่านแล้วก็นักแสดงน้อยๆของเราทุกคนด้วยนะครับขอบคุณมากนะครับน่ารักมากเลยครับ ต้นไม้แห่งปัญญานะครับ
ค่ะขอเสียงปรบมือให้กับทุกท่านอีกครั้งแล้วก็นักแสดงตัวน้อยๆบนเวทีด้วยค่ะแล้วเราพบกันใหม่นะคะเดือนพฤศจิกายนปีหน้าค่ะการประชุมครั้งที่ 3 Annual National Health Professional Education ค่ะ
ถ่ายรูปไหม
อาจารย์ท่านใดอยากจะถ่ายรูปกับนักแสดงตัวน้อยเชิญด้านหน้าได้นะคะ